Today's video is dedicated to medications. In recent years, I've relied almost exclusively on psychological methods for treating anxiety in my work with clients. However, I believe it's important to provide my viewers with comprehensive information about all the effective treatments options available. The medications that, according to the recommendations of all psychiatric associations, are prescribed as the first-line treatment and have proven effective for most people with panic attacks are SSRIs, or Selective Serotonin Reuptake Inhibitors. If we examine the guidelines in the United States, Canada, and the United Kingdom, we will see the same recommendation: SSRIs as the first-line therapy. This has long been an established international standard of treatment for the simple reason that no other class of medications come close in terms of balancing effectiveness with minimal side effects. For this reason, I will focus primarily on the nuances of treatment with antidepressants from this group in this video. That said, in the second part, I will also explain what other common medication strategies exist and why they are unjustified. I will not describe each of these drugs individually, firstly because there are already plenty of such videos online, and secondly because I don't see much point in doing so. All 6 treatments in this group work in almost the same way. Before prescribing any medication, your doctor will ask you to undergo a basic set of tests: a complete blood count and biochemical blood test, thyroid hormone levels, and electrocardiogram. If everything is within normal limits, the typical plan is as follows. We select one of the 6 SSRIs, start at the lowest dose, and gradually increase it over the course of several weeks to a level slightly above average. There are a few important points to keep in mind here. First, SSRIs almost never work right away. Their effect is always delayed by several weeks. This applies both when starting the medication and when increasing the dose. Whether it's the first pill or a later dosage increase, the brain responds with a delay of about 2 weeks. Second, the dose required to achieve the anti-anxiety effects of the antidepressant is often higher than the starting dose, sometimes several times higher. In some cases, we even reach the maximum recommended dose. As a result, from the moment you take the first pill to reaching the target dose in several steps and finally experiencing the desired effect, it typically takes about 1 to 2 months. At the same time, nearly 1/3 of people who start taking SSRIs quit within the first month, meaning they never give the medication a chance to show its effect. This often happens because people either don't wait the necessary 2 months and stop taking it when they don't feel results, or their doctor prematurely switches them to a different treatment. Why some psychiatrists overlook the need to allow time for the medication to take effect is beyond me. I consider it a clinical error. Another reason for ending treatment too soon is side effects. Unlike the desired effects, side effects often appear quickly, sometimes within the first few days. Even so, this doesn't necessarily mean that you will experience them. In fact, most people don't notice any unwanted reactions. Still, it's helpful to understand what they might involve. In addition to unpleasant physical sensations such as nausea, dizziness, or headaches, one particularly discouraging effect can be a temporary increase in anxiety, the very symptom that the antidepressant was prescribed to treat. This unexpected reaction can put people off medication for a long time. Should you encounter this, be aware that 90% of side effects tend to resolve on their own within approximately 2 to 3 weeks of continued SSRI use. You simply need to get through this initial period. To ease this process, you can discuss with your psychiatrist the option of temporarily lowering the dose, meaning you can take a small step back at any stage and resume increasing the dose a little later. In addition, your psychiatrist may prescribe a short 2-week course of anti-anxiety medication such as Valium, Ativan, or Vistaril. These can help ease the potentially difficult first weeks of treatment. The previous discussion focused on the challenges and undesirable effects of SSRIs, but what positive changes can we expect from the medication? As I mentioned earlier, these typically become noticeable no sooner than after a month of consistent treatment. The first improvement you are likely to notice is a gradual reduction in the frequency and intensity of unpleasant physical sensations. You'll begin to experience fewer episodes of palpitations, blood pressure spikes, body tremors, dizziness, hot flashes, and breathlessness. This occurs because SSRIs have a direct impact on the cardiovascular, gastrointestinal, and vestibular systems, as well as cortisol levels and the body's sensitivity to carbon dioxide. The second change involves shifts in emotional processing, both in how you interpret internal sensations and external events. The physical effects of adrenaline no longer feel as alarming, and catastrophic thoughts about previously frightening situations begin to fade. Taking public transport or traveling far from home will no longer seem like life-threatening scenarios. A brief side note here. Strictly speaking, it's not entirely accurate to refer to these medications as antidepressants, since, as you can see, their effects extend far beyond just improving emotional well-being. These are broad-spectrum medications that are now used not only in psychiatry but also in neurology, gastroenterology, and cardiology, for example in treatment of chronic pain, irritable bowel syndrome, arrhythmia prevention, heart failure management, and even to reduce the risk of thrombosis. Summarizing the standard treatment approach, let me outline the recommended steps once again. If you are seeing a psychiatrist specifically for panic disorder without additional concerns such as sleep difficulties, the typical recommendation is to start with one SSRI taken on a regular basis. If needed, this might be temporarily supplemented with a medication like hydroxyzine, alprazolam, or clonazepam. Over the course of 2 to 3 months, your doctor will gradually increase the SSRI dose to a moderate level as indicated in the prescribing guidelines. They will then reassess your condition. If the effect is sufficient, you will likely be advised to continue taking the medication for about a year. If the response is inadequate or absent, your doctor might consider further increasing the dose. If that still proves insufficient, adding a second antidepressant might be an option, but the additional steps are typically only necessary several months into treatment and for a small percentage of people. For most patients, a single medication and a moderate dose is enough. The treatment strategy described above is straightforward and effective. As a psychotherapist, I find working with panic attacks particularly rewarding because both psychological interventions and medications often deliver rapid, dramatic improvement and significantly enhance people's quality of life. Yet, for some reason, many specialists fail to take this clear and effective road, opting instead for treatments that are clinically unjustified. So let's view some approaches that should not be used to treat panic attacks. Prescribing an antipsychotic, anticonvulsant, or benzodiazepine is one such approach. The first two groups have no proven effectiveness for treating panic attacks and can cause pronounced drowsiness, while the latter carry a risk of dependence and are not recommended as a course exceeding 14 consecutive days. Another questionable practice is prescribing all these medications at once alongside an SSRI. This approach is as common as it is illogical. Antipsychotics and anti-epileptics should not be prescribed without clear clinical indications. Such an indication might be, for example, a bipolar disorder characterized by alternating periods of elevated and depressed mood lasting several weeks or months each. That being the case, diagnosing bipolar disorder requires a psychiatrist to conduct a thorough assessment of the person's life history, along with a clear explanation and clinical reasoning behind the diagnosis during the consultation. Achieving this in a brief 30-minute appointment is virtually impossible. Bipolar affective disorder requires careful and ongoing observation, and when such a diagnosis is established, panic attacks are generally no longer the primary focus of treatment. Another strategy, not exactly incorrect but far from optimal, is prescribing an antidepressant that doesn't belong to the SSRI group. Such decisions require well-defined clinical reasoning. For example, This may be appropriate if a person has previously experienced persistent and difficult to tolerate side effects from 2 different SSRIs, particularly side effects that are typical for this class of medications, such as reduced sexual function. In such cases, recommending an alternative like trazodone may be reasonable. Why in general do we tend to avoid prescribing other antidepressants as the primary treatment from the outset? Because these alternatives are more likely to cause side effects, and often quite unpleasant ones, ranging from weight gain, which is relatively common, to rarer but more concerning issues like urinary difficulties and heart rhythm disturbances. And here is my personal favorite. Products like Calm's Back Rescue Remedy, Highland's Nerve Tonic, Quietude, Sedalia, Byron Homeopathic Remedies, and various magnesium supplements. They're all absolutely harmless and equally useless. Every one of these is essentially a placebo with no trace of real effect, aside from the placebo effect, of course. Whether or not it's worth relying on placebo treatments is a separate ethical question. I believe the process of choosing medications and starting treatment is now clear. Next, I'll address some common questions. How long should treatment continue? How should it be discontinued? And perhaps most importantly, what happens after you stop taking it? These topics are rarely discussed in detail. Even in professional literature, most research tends to focus only on short-term effects of medications. Discontinuing an antidepressant should be done gradually, by slowly reducing the dose, and the slower the better. According to standard guidelines, this typically means decreasing the therapeutic dose by 25% per week. In other words, tapering off the medication over the course of about a month. However, I recommend going even slower, spreading the reduction over 2 to 3 months. This approach helps minimize the risk of withdrawal symptoms or discomfort during this phase. So when should you start tapering off SSRIs? The recommended duration of treatment is 1 year. Why not more or less? Because after a short course, the risk of panic attack relapse remains fairly high in the months following discontinuation. On the other hand, extending treatment from 1 year to 2 has not shown to significantly reduce likelihood of symptoms returning. In essence, 1 year of treatment builds a kind of psychological safety buffer for the future. How long that buffer will last is an open question. According to various studies, about 1/3 of patients experience a recurrence of panic disorder symptoms within a year after stopping treatment. That may not sound particularly encouraging, but there is one crucial point to keep in mind here. Medications are effective and they work quite well for as long as they are taken. Even so, they cannot permanently recalibrate your mental state. To conclude, let's compare 2 treatment approaches that research shows to be roughly equally effective: SSRIs and cognitive behavioral therapy. Let's start with the time frame in which results become apparent. As I mentioned earlier, the full anti-anxiety effects of SSRIs tend to unfold around the 2nd month of treatment. Cognitive behavioral therapy may require a bit more time. It generally takes roughly 10 sessions before exposure exercises to anxiety-provoking situations and bodily sensations are introduced, steps that meaningfully expand your comfort zone. Although session frequency can be adjusted, making it possible to achieve the same progress in roughly half the time with a more intense schedule. The next important factor is the level of commitment to each treatment approach demands. Here, SSRIs clearly offer a more straightforward path. You undergo some basic tests, visit a doctor for a prescription, collect your medication from the pharmacy, and then take your prescribed dose once a day. Psychotherapy, on the other hand, requires sustained engagement not only during sessions but especially in the time between them. You'll need to maintain thought records and actively confront anxiety-provoking situations on a daily basis, often for several weeks or even months. SSRIs are often accompanied by short-term reactions that typically arise within the first couple of weeks, such as nausea, dizziness, headaches, and drowsiness. There are also side effects that may persist throughout the entire course of treatment, namely erectile dysfunction, reduced sexual desire and difficulty reaching orgasm. Research shows that these issues to some extent affect roughly half of those taking SSRIs. But a significant number of my clients have mentioned that before starting medication, their anxiety had already left them feeling so overwhelmed that sexual concerns felt insignificant by comparison, making these drawbacks seem like a negligible trade-off. The primary challenge with CBT, on the other hand, is discomfort that arises from intentionally confronting your fears during exposure exercises. Another important factor is the cost of each treatment option. As of 2025, in the United States, a month's supply of generic SSRIs typically ranges from $10 to $30 with insurance and from $20 to $100 without insurance, depending on the medication and pharmacy. In comparison, the cost of a single psychotherapy session can vary widely depending on the therapist's qualifications and location, typically ranging from $100 to $250 per session, and in some major cities, rates can climb even higher. In this regard, SSRIs are often the more affordable option. At the same time, the greater investment required for psychotherapy may prove more rewarding over time, as its benefits tend to persist longer after treatment ends compared to medication. This is largely because throughout the course of therapy, people develop and internalize specific skills for managing anxiety symptoms. These skills eventually become second nature, helping to prevent future flare-ups even after therapy concludes. As you can see, there is no universally correct answer to the question of whether medication is the right choice for treating panic attacks. The decision should be made based on your personal circumstances, weighing the pros and cons either on your own or with a psychotherapist. The essential point is that effective treatments for anxiety are widely available. There is no reason to deny yourself the opportunity to improve your life by embracing at least one of these options.